Good morning, everyone. Welcome to Pediatric Grand Round. Thank you for joining us in person. We're in the Mill Mountain Conference Room at Tanglewood. If you'd like to join us, and thank you for listening in online. Today's speaker is Dr. Robert Strominger. Dr. Strominger joined Carilion, New River Valley Otolaryngology in January of 2023. He brings over 20 years of experience practicing general otolaryngology, laryngology, voice, and swallowing to Carilion Clinic. He grew up in Albany, New York, attended Washington University in St. Louis as an undergrad, and Albany Medical College. He then completed his residency at WashU. He went on to the National Institute of Deafness and Other Communication Disorders as a senior staff fellow to study voice disorders. From there, he spent most of his career in Ithaca, New York. He was the director of Ithaca College Voice and Swallowing Clinic in collaboration as part of the Ithaca College Speech Language Pathology Program. He also ran an ENT residency clinic at the University of Rochester School of Medicine. He then spent several years at the University of Texas in Tyler, where he started a new ENT program. Bringing this experience to Carilion Clinic in collaboration with speech therapy, he is collaborating in a voice and swallowing clinic in the otolaryngology office at Carilion, New River Valley. He's an avid runner, bicyclist, and outdoorsman, and he spends most of his vacation days with his children and grandchildren all across the country. Please join me in welcoming Dr. Strominger.
So thank you very much. And I am a surgeon. I want to start there. But the real focus of this talk is why you should not send me your patients. And I wrote this for this conference. There are pieces I've taken out of previous talks, but it's not a CAM talk. It's my first time giving it, so bear with me. And it's really because of what we're seeing in the community and the patients that we're being sent. So I have no conflicts related to this, but I have a financial interest in a startup company, Quadrant Biosciences. So I want to talk about what the problems that I'm seeing as I'm being sent these patients. And it's just not this area, it's the entire country. There's an overprescribing of antibiotics. And so we want to understand, when should we put tubes in? When should we give antibiotics for otitis media, for otitis externa? Talk about tonsillitis and tonsillectomy in children, and at the end, if we have time, what I consider kind of the modern treatment for peritonsillar abscess. So what are the risks of antibiotics? There are many. There's anaphylactic access to penicillin and other antibiotics. We're seeing young kids in our office with Clostridium difficile from broad-spectrum antibiotics being given. You get a gut microbiome dysbiosis. We're really causing lifelong problems for these kids by overprescribing antibiotics. They lead to the development of asthma, juvenile arthritis, diabetes, Crohn's disease, and mental illness. And all of this is new. I mean, we didn't realize this 20 years ago, but we're seeing an association between these antibiotics and all of these illnesses in these children. You can get Stevens-Johnson syndrome, obviously, as depicted in that picture, and we're seeing more and more antibiotic resistance. And what I wanted to show you is the Carilion antibiogram from a couple of years ago. I couldn't find the 2023 yet. And first of all, the first thing to remember is that group A strep, ampicillin, amoxicillin, 100% sensitivity. But as you get to what we consider stronger antibiotics out in the community, azithromycin only has a 41% sensitivity rate, strep pneumo 70%, and if you go to clindamycin, it's similar. We're also seeing those resistances for the various strains of Staph aureus. So amoxicillin still is the gold standard for the treatment of group A hemolytic strep. So I'm going to go through some patients as I discuss this. So patient 1 is a 3-year-old female with recurrent otitis media, been on 9 courses of antibiotics for ear infection, including 3 courses over the past month. She'll tug at her ears and taken to the family medicine office or urgent care out there in the community and being told the ears are red, diagnosed with an ear infection and put on antibiotics. She's been on multiple courses of antibiotics, including most recently ceftriaxone injections, and I guess I should use Ceftonir instead of Omnicet there. Only once, months ago, she had high fever and was inconsolable for these ear infections. So, first of all, middle ear disease is common in children. They have an immature eustachian tube, which we'll get to. They have a transient or a physiologic hypogammaglobulinemia, which occurs, so they're at increased risk of infection. It takes about 2 years to 3 years of age for their immune systems to catch up from the drop of immunoglobulin after being born. They're exposed to all the viruses in daycare and school, and in the high-risk population, they're exposed to secondhand smoke. We certainly see a lot of that out in the Galax and Hillsville area, West Virginia area that we are servicing. The eustachian tube in children is much more horizontal than in adults, so it doesn't drain as well. It's floppy, the cartilages aren't formed yet, so it's very soft, and the muscles that allow it to pump, to allow it to drain, are not mature. They're offshoots of the palate muscle, and just like their palates aren't developed well, or the musculature, the muscles aren't developed. So you are at increased risk of middle ear disease because the tube draining the middle ear isn't mature yet. So obviously we're looking at the tympanic membrane. What we see, what you have to realize is that the external auditory canal is not straight. There's oftentimes a big curve because of the TMJ, and it can be very difficult to see the eardrum in these little kids. But what we want to see is a nice clear eardrum. You can see through it. That's the you see some of the osseous structures underneath. Sometimes back here you can see the incudostapedial joints. But it can be very difficult. Oh, here, sorry, looking backwards. Incudostapedial joint can be very difficult sometimes to see the eardrum. And so here are some examples. So how many residents are here? Okay, we'll start with you. A, what do you think you're seeing there? Quickly.
It looks like a normal ear.
Okay. B, next.
A little bit of serous fluid on here.
C,
It looks a little erythematous surrounded.
D,
Some bulging of the eardrum.
what do you think?
Some bulging, some fluids.
Okay. E,
More bulb.
Bulging for sure.
F,
Maybe some bulging, yeah.
G,
Definitely looks.
Not look happy.
okay, doesn't look happy. Good enough. H, okay, and I. What's that? Good. Okay, good. And I'm going to tell you that what I'll see in our practice is every one of these kids put on antibiotics. But 50% of the time, I can't tell what's going on, or more. 50-75% of the time, I can't tell what's going on in these kids' ears that are sent to me. And so I really rely on that pneumato-otoscope, right? If you don't have it on your otoscope, you shouldn't be looking at ears in this population. You've got to see what's happening with the movement of the eardrum. Or get a tympanogram for your office, or both. These are cheap, and I do them, my PA does them, and what you're looking at is their movement of the eardrum, and that's really the decision-making. What do you see on pneumotoscopy, and if you have it, what do you see on tympanometry? In the normal ear, you have a nice peak, type A, right at 0 pressure. Type C, where the eustachian tube isn't working well, maybe a very mild effusion, you'll have negative pressure, and an effusion with no movement of the eardrum is going to be a B. And this is the only one you're worried about. Whether you're going to decide to send them to me for surgery or you want to put them on antibiotics, anything here doesn't need treatment. The only ones you're worried about are the ones down here. And I can't tell that by just looking in the ear. I need to get some objective data. If you're lucky, and most of the time, honestly, we don't have access to hearing tests when we're assessing the kids for the first time. We could use 3 or 4 more audiologists here. We don't have them. So I kind of end in that previous slide most of the time. But if you really want to be able to know what you should do with the kids, you get a hearing test. You want to see, is there an air-bone gap? Is there conductive hearing loss compared to the bone line that you're able to see? This is where they should be able to hear. Middle ear fusion, air-bone gap, they've got hearing loss, and that's what you're looking for. Ideally, anybody I put tubes in, I have this data, but here at Carilion, we have such a shortage of manpower that we don't always have that before we put tubes in, so we use everything else. So acute otitis media is very common in kids. 80-90% of kids will have acute otitis media. Viral pathogens are very common. About 35% of upper respiratory infections will lead to acute otitis media. You've got RSV, you got coronaviruses, you got adenovirus, vocaviruses, and rhinoviruses. All of these cause acute otitis media. Bacterial otitis media, strep pneumo is the most common, Moraxella catarrhalis, and Haemophilus influenza. That's your board question right there, guys. Okay, when you're taking your boards, those are the 3 things you need to know. What's interesting is, and we talked about it with one of the providers before everybody came in the antibiotic era, vaccine era, with the various vaccines, what we're doing is we're reducing the absolute number of ear infections that kids have. But those that start having them tend to have a more resistant infection, non-typable H flu, more likely to need tubes placed. So even though we've reduced the numbers, those that get them might need intervention. But an ear infection isn't a red eardrum. An ear infection is fever, pain, an inflamed bulging eardrum, inconsolable kid. If a kid is asymptomatic, for the most part, they're tugging at the ears, okay, you look and it's red, okay, that's not an ear infection. That's not an acute otitis media. That's not an acute infection. Watchful waiting is always okay. Mom brings in a kid that first day, they're pulling at the ears, you look, you think there's an infection. Because there's such a high prevalence of viruses that cause these, and because all infections for the most part are self-limited in one way or the other, just watch. Very common in Europe. We're more hesitant to do that in the United States, but certainly an option as opposed to prescribing the antibiotics right off the bat. And the guidelines for the American Academy of Pediatrics really stratifies between how bad is it, right? And what's the age. The younger may be more likely to treat, the older, watchful waiting, but if the severity of the symptoms aren't bad, just keep an eye on it. Give the parents antibiotics if you want to, tell them to hold off on set for 72 hours or so, and see what happens to the kids. And again, amoxicillin is the antibiotic of choice, obviously, unless there's a known allergy or unless the kid's just been treated with it. But what we see is the kid's been treated with the amoxicillin, they're brought back a couple of weeks later, well, the ear doesn't look normal, oh, well, we better put you on a quote-unquote stronger antibiotic, even though the kids are relatively asymptomatic. So that leads to what happens, right? Otitis after an ear infection. Well, you get otitis media with effusion. You can get otitis media with effusion without that previous history of ear infection, and that's why we have screening programs in schools to do hearing tests and stuff to diagnose that asymptomatic effusion. But it's fluid occupying the middle ear space because of that immature eustachian tube. The mastoid produces fluid. That's what it does. And absorbs gases. And so all day long, you and I are drinking the fluid that's produced by our mastoid. It starts in the mastoid, drains through the adductus antrum, into the middle ear space, down the eustachian tube. And if that eustachian tube is plugged like a shower drain, it's going to back up and you're going to get fluid in the middle ear space. It's just normal physiology. It can be serous, which is probably what you saw, we'll get back to that, or mucoid, we suck out this thick, goopy stuff. It's like rubber cement consistency. And that's the kid that it never goes away on. But it's asymptomatic other than hearing loss, okay? These kids aren't having pain, they're not having fever, and they don't necessarily know it's there. And the important thing to understand is, after an acute otitis media, effusion can last for up to 3 months. Normal, absolutely normal to have fluid up to 3 months after an ear infection, whether you're pediatrics or adult. And we'll get sent the kids 2, 3 weeks, 4 weeks after that initial infection. They've already been on 3 or 4 courses of antibiotics. They don't have a previous history, and they don't need intervention. So the clinical guidelines for me for the placement of tubes is for chronic otitis media with effusion. If the effusion lasts more than 3 months, up to about 6 months, so you have a window, you have a type B tympanogram, you get an audiogram that shows a conductive hearing loss. If you're lucky, you can get it. You're worried about speech and language developmental delay. You see some type of structural damage to the tympanic membrane, like a retraction pocket, or the development of incudostopediapexy, or if they have some type of other craniofacial abnormality, like you'd see in Down syndrome or a cleft palate, where those muscles aren't developed properly. And then I'm always asked, should we do an adenoidectomy? You don't do an adenoidectomy with the first set of tubes, second or third set of tubes. And so, again, if you see a kid with an effusion, they don't have any other symptoms, mom's not worried about hearing loss, you don't know how long it's been there, follow these kids for a little while, see if it goes away. I use time of year a lot. I'm much more aggressive if a kid is sent to me in like August or September with effusion than I am a kid sent to me this time of year. Because just by, they come in April, May, June, they've had a bad winter, we can get probably 50% or more of those kids better through the summer just by leaving them alone, and then you self-select for that smaller percentage that needs to have tubes before the school year starts the next year. So here's the whole clinical guidelines, practice guidelines that have been published. The bottom part is me, so I blew up the top part. And so it's very confusing. I look at these things and go bleary-eyed, but I circled the ones that are important. And the only thing that's important is there a middle ear effusion in the ears? If there's a middle ear effusion, whether there's recurrent otitis media or not, then you can offer or should perform tubes. If the ears look good at the time of the evaluation, the kids are clearing themselves naturally, even if you think they've had recurring infection, they don't need tubes placed. So the only thing that's important is what's in the middle ear. Is there effusion or is there not? Because if there's not effusion, I'm not going to do surgery. Now that said, when I was a resident, we didn't publish this, but we decided to do a little study on, here we are in the operating room, putting tubes in. And we said ahead of time, what are we going to find? Are we going to find effusion, or is the middle ear space going to be clear? So we do that, we make our myringotomy, and we were right about 50% of the time. So fully appreciate how difficult it is to know, and maybe err on the side of caution, but that's where the objective data with the tympanometry and the pneumotoscopy and hearing testing, if you have it, can be very helpful. So quality measures, do you know these MIPS measures, residents, that you have to do? It can be up to about 5% of your income out there, and you have to meet these quality measures, you report them, and then they decide whether you're within the percentage. But there's actually a quality measure looking at the overuse of antibiotics in these kids. And so they make it so hard to read and understand, but the couple important points are systemic antimicrobials have no proven long-term effectiveness and have potential adverse side effects in kids with otitis media with effusion. And the measure is clinicians should recommend against using systemic antibiotics for treating otitis media with effusion. These kids that don't have the fever, that don't have other symptoms of infection should not be put on antibiotics. So you'll be signing contracts out there at some point where you're going to have to be measuring this. okay? Because it's pediatrics, family medicine, ENT, that this is a quality measure for. And the other thing I want to point out is that by definition, if you have an otitis media, you have quote-unquote mastoiditis. We see this from the ERs and urgent care all the time, where a kid will come in with, or an adult will come in with ear pain, they'll press a little, oh no, and they'll get a CT scan and will be consulted for mastoiditis. So the mastoid is this honeycomb network of bone lined with mucosa, and I told you the drainage already. So if you have a middle ear effusion or otitis media, by definition, you'll have mastoiditis or mastoid effusion. The acute coalescent mastoiditis, where you have erosion of the bone, maybe meningitis, abscess, those kids are really, really sick. And I've been practicing since 1990, I started my residency in 91, I've been practicing since 97, I've not seen one in that length of time. And we were talking before, he used to see this stuff in the 70s and 80s, but we don't see this anymore. So just if you have a kid with mastoiditis and CT, the key question is there evidence of coalescence? Is there evidence of infection? I mean, of a complication. So here's patient one. So what do you think? Should that kid be put on all those courses of antibiotics or not? Right? Only once, months ago, she had a high fever and was inconsolable. So this kid, I guess, needed one course of antibiotics. The effusion didn't clear and kept on being treated for that effusion. So let's break it into two different scenarios. Scenario one, they come into my office and the middle ear is clear, type A tympanograms and normal hearing. I'm not going to put tubes in that kid, okay? Scenario B, I see an effusion, type B tympanograms, conductive hearing loss and speech delay. It's been several months, 3-4 months since all this started. We can talk about tubes. Again, it might depend on the time of year and everything, but that kid probably should get a set of tubes, and that's the indication right there. So patient two, 6-year-old male, spent the weekend swimming in the lake, developed a right ear pain and drainage, taken in for treatment and started on amoxicillin clavulanate. A week later, he continued to drain, was switched to clindamycin and referred to ENT for a resistant infection. So treatment of otitis externa and otorrhea of any source. Otitis externa is Pseudomonas and Staph aureus. We don't have an FDA-approved oral drug in kids for Pseudomonas. If you have a tympanic membrane rupture or tube otorrhea and it's really acute, you can add H-flu, but you still have to treat the Staph aureus and the Pseudomonas. And you want to treat with ototopical antibiotics. There is no role for oral antibiotics in the treatment of otitis externa, tympanic membrane rupture with drainage, or tube otorrhea. You want to treat with an ototopical fluoroquinolone, ofloxacin or ciprofloxacin, dexamethasone, because you need to treat that Pseudomonas. I don't use neomycin-based drops because there's a lot of resistance to them and there's a lot of allergy to them. It's because I'll see people getting worse, they'll be sent to me, I just switched them to one of the other fluoroquinolones and they do better. So no role for oral antibiotics in this, and lo and behold, it's a MIPS measure, it's a quality measure. Again, they make it hard to understand, but the important thing is the last line. Clinicians should not prescribe systemic antimicrobials as initial therapy for diffuse, uncomplicated otitis externa, unless there's extension outside. You're getting facial cellulitis or perichondritis or something like that, or there are other issues going on. So very important. We see this every day in our clinic, and we talk to my colleagues around the country. It's the same, despite this being a measure for ENT, family practice, and pediatrics. So, again, should have been treated with an ototopical antibiotic if the ears are filled with debris, maybe suction it out, but should have been treated with ofloxacin or ciprofloxacin-based antibiotics. So let's go through this again. So I'll tell you what you're seeing here. A is an effusion, right? Again, very difficult to understand that, but no antibiotics. B, serous effusion, we had that right, no antibiotics. C is a normal eardrum, no antibiotics. D is influenza. So otitis media, but also had nasopharyngitis, high fevers, and all the other symptoms of flu, tested positive, no antibiotics. E, fevers, inconsolable, purulent middle ear effusion, antibiotics. Mucoid effusion, they look exactly the same oftentimes, and that's why you have to use symptoms and signs to decide whether you want to treat. Bullous meningitis, it's a virus infection, no antibiotics, you can put them on ototopical if you want, really painful, especially when they rupture with a burst of blood. This is going to be this is more common than suppurative otitis media with tympanic membrane rupture, but everybody's diagnosed with a rupture, like bullous meningitis. This is otitis externa, so ototopical antibiotics, and this is tube otorrhea, so ototopical antibiotics. Especially once tubes are in place, there is no role for oral antibiotics. They can be treated with ototopical antibiotics. But I can tell you, every one of these patients was treated with oral antibiotics before being sent to us. Yes, sir.
I was taught that mycoplasma can sometimes cause bullous meningitis. Is that not
It is.
viable now?
It probably is. Yeah, it is. But you still don't need to treat it. Patient 3, a 2-year-old, note the age, on 5 courses of antibiotics over the past year for recurring strep. Throat is red. Rapid strep test is performed and has been treated with antibiotics every time. October 25th, positive strep, amoxicillin. November 1st, positive strep, amoxicillin clavulanate. November 15th, azithromycin. Note the timeline, okay? January, negative, looks like strep, put on antibiotics. February, negative strep, treated with clindamycin because it looks like strep and needs a stronger antibiotic. We see this every day in our practice here. So what are the tonsils? It's a ring of lymph nodes, lymphofollicular tissue in the back of the throat, all the way around the back, Wall-Dyer's ring. It aids in immune development in infancy. It's like another thymus gland. Obviously, that function ends relatively quickly, but it's immune surveillance and sequesters and fights infection, but the bacteria can hide in it too and kind of become the source of infection at times. Which is strep? You know, I keep on hearing, reading in the notes, looks like strep. You can't tell. All tonsillitis looks the same. Is this strep? Is this strep? And it's impossible to know. So how can you tell? Well, first of all, you have to understand the most common cause of tonsillitis is viral. Influenza, coronavirus, and it's interesting, I gave this piece of the talk in the middle of the pandemic, and people were on coronavirus. So we've had coronavirus with us forever as causes of otitis media and tonsillitis. Perhaps that's why kids didn't do as badly during the pandemic, because they already had a little bit of exposure to that, to those viruses. Anyway, adenovirus, Epstein-Barr virus, herpes viruses, HIV in the at-risk population. Only 15 to 30% of tonsillitis is caused by bacteria. Of that 15 to 30%, only 20 to 30% is caused by strep. Others are staph aureus, chlamydia pneumonia, chlamydia trachomatis, Neisseria gonorrhea in the high-risk populations for those, obviously. But, you know, college campuses, teenagers, something you need to think about. And everybody's concerned about the complications of group A strep, rheumatic fever, pericarditis, scarlet fever, which is the photo, post-strep, glomerulonephritis, pandis. I've seen pandis before. It's quite remarkable when these kids start becoming autistic when they have the strep. Really fascinating. And then they get better again. Juvenile psoriatic arthritis and psoriasis can also be caused by group A strep infection. But is rheumatic fever really a concern in the United States? Certainly, it looks like it's more of a concern in like Hawaii and like America Samoa, where and in the Asian population, where it's 1.1 to 1.5 cases per 1,000, but nobody's studying this, so we don't know what the modern data, most recent data is. But if you look at Tennessee, in 1980, from 1977 to 1981, where they did study it, it's 0.6 cases per 100,000. In Utah, it was in the 80s, it was 3.7 cases per 100,000. And again, we see it more in the Asian, Pacific Islanders, Hispanics and Blacks and Native Americans, but it's really not that common. So we're looking back in history that we need to use the strep, but there's no data to support that, actually. So the question is, are we doing more harm by treating? We don't know the answer to that question, but I will say, I'm going to say it a few times, is do not treat without a positive strep test and discontinue if the cultures are negative if you've decided to treat with a negative strep test. If you followed up the rapid strep with a full culture, if everything's negative, stop, don't prescribe or get them off the antibiotics you prescribe. How can you tell? Well, obviously, get your white blood cell count, look for left shift, and see if it looks bacterial or viral. Look for a lymphocytosis in the kids. Are there atypical monocytes? Again, more likely to be viral than bacterial in that setting. Do mono testing. It's Epstein-Barr virus. You get more of a lymphocytosis. The incubation period is 4 to 6 weeks. I have parents say all the time, but nobody's exposed. Maybe nobody else has it, but maybe they did a month or two ago and you got exposed. Obviously the symptoms of infectious mononucleosis, I don't have to go over here, see more in the teen population, but most of us will test positive if you do EBV titers. And the other thing to remember is that you can shed virus for 18 months. I mean, you can have real prophylactic courses of mononucleosis. The monospot is very specific, but it's not as sensitive. And don't use in young kids. It's not very sensitivity, not very sensitive. The sensitivity rates under 4 are 27 to 76%. And it's negative for 1 to 2 weeks after the onset of infection. We'll get kids from the urgent care all the time. Well, the monospot was negative. Well, symptoms started 2 days ago, right? And so we will follow that up with EBV titers in the office. It doesn't become positive for 2 weeks or so after the onset of infection. Very important to understand. There's no role for getting it in the acute infection state. It's not going to help you. Get the titers, get the white blood cell count, and see. And obviously, get the rapid strep. If the rapid strep is negative, don't treat. Which brings us to the rapid strep testing. And if you remember this, the patient, that patient was tested every week or so for about a month and put on more and more antibiotics. But if you look, you can have positive tests out to almost a month after the initial test. You're not testing viability. You're testing whether the bacteria was present or not. So once you get that positive test and parents bring the kid back, don't retest if you treat it. And again, culture and sensitivity. If the rapid strep test is negative, if you think you might put that kid on antibiotics. And remember the age of that patient. That patient was 2 years of age. The Infectious Disease Society of America guidelines regarding group A strep, and this is reiterated by the Pediatric Association, does not recommend strep testing in children younger than 3 years of age, and obviously asymptomatic kids. Group A strep is rare in less than 3 years of age, and rheumatic fever extremely rare in this age group. So complications of strep under 3 is really rare, and so what's doing more harm? Not testing and treating, or treating with antibiotics. Treating with antibiotics can be much more harmful. Yes, ma'am?
You say not to retest with the rapid strep because they'll likely still test positive. If they're still symptomatic and they come back, say, a week and a half, 2 weeks later, would you recommend reculturing or just assuming that that they failed their treatment in the first place?
I would reculture and look for other causes like mono. If it's a teenager, other, sexually transmitted disease and stuff like that. Okay. Does that make sense?
Yeah.
So, and then strep carriers, we get sent these patients a lot that always test positive, but they're asymptomatic. They don't need treatment and they don't need surgery because they're not at risk of getting sick and they're not at risk of spreading the disease to others. Repeated use of antibiotics in strep carrier state is unnecessary and tonsillectomy is unnecessary. We're not going to eradicate it. When we're doing tonsillectomy and adenoidectomy, we're removing subgroups of the tonsils. We're never removing any of them. And I do an intracapsular tonsillotomy technique. So I'm not even shucking out the palatine tonsils. I'm shrinking them down. So I leave a little bed over the muscle so that it's a more rapid recovery, there's less risk of bleeding, and the patients do well. So we're not removing tonsils. We're not going to get rid of this strep carrier state. So if you're concerned about strep carrier, if you want an opinion, send an infectious diseases, because that's what I'll do, but I'm not going to do tonsillectomy on a strep carrier. Oops, we've died. The clicker died or something. We're not moving. Oh, it did move, okay. So it's a MIPS measure, right? So do testing and only treat for positive tests. Again, the important part of the measure is at the bottom. Because the clinical features alone do not reliably discriminate between group A strep and viral pharyngitis, except when other viral features like rhinorrhea, cough, and ulcers and hoarseness are present, don't treat. So recommend swabbing the throat and testing for for group A strep by rapid antigen testing and/or culture. So swab and culture and treat for positive tests. Don't treat because it looks like strep. Again, I know the people in this room know this, but I wrote this based on what I'm seeing sent to us from the community at large. So, and so if you are going to reduce risk, it's thought that the risk reduction is about 1 per 100,000 or a number to treat of 10,000 to prevent 1 case of acute rheumatic fever. So again, there's a lot of data out there saying that we really need to be more selective in the patients that we treat for group A strep. And this is funny, Dr. Holly and I talk about all this time because we read this in a paper and we don't get the Carilion medical students, but we get the VCOM medical students all the time. And treat it and you'll be better in 7 days. Don't treat it and you'll be sick for a week. And I think that's so true. So all of these are self-limited. It doesn't matter what it is. They're self-limited infections. And if you think you might be able to reduce a complication, which I think is controversial, treat. If you don't treat. Yes, ma'am.
Under what circumstances would you start antibiotics pending culture? Because I tend not to.
Yeah, really good question. I tend not to. Here's the problem we face, and I fully appreciate it from these kids are pulled out of school, they're sent home from school by the school nurses, and they can't go back until they've had treatment. And that's the counter argument I get by parents all the time. I can't send my kid back to school until they've been on antibiotics for 24 hours. And it's a problem. I don't know about Roanoke because I'm not taking care of many of these patients, but these are parents coming from Galax, Hillsville, Mount Airy, out to Princeton, West Virginia. That whole region is what we're seeing all this with. And again, gonorrhea and chlamydia, GC swab for at-risk patients. It's up to about 3% of the college kids have gonorrhea, chlamydia. It is the oropharyngeal gonorrhea is the source for multi-drug resistant gonorrhea. In 2012 is when that first Kyoto strain came out. It was traced back to Kyoto, Japan, and it came from an oropharyngeal swab. They changed plasmids with other Neisseria strains in the oropharynx, and that's where the resistance comes from. It lays dormant, leads to reinfection, and it's a big problem. So if you're treating the high school and college kids where they might be at risk, make sure you do a GC swab for tonsillitis. So here's the clinical guidelines that came out. So recurring infections, and you have to realize it's not specific to strep. It's recurring infections. 7 infections in 1 year, 5 infections a year for 2 years, 3 infections a year for 3 years. You want symptoms of infection, not just mom says the kid's throat is sore, but actual signs and other symptoms of infection with fever, cervical adenopathy, you see exudates, positive strep test. Obviously, there are always modifying factors, like the kids have a lot of other associated issues. They have antibiotic resistance. They've had a couple of peritonsillar abscesses or other concurrent indications, which we'll get to, like tonsillar hypertrophy. So again, this kid, you could argue, needed the first course of antibiotics, but not the rest. So patient 4, tonsillar hypertrophy, wakes up in the middle of the night, wakes up tired, mom's scared because he's gasping for breath. He's been evaluated for ADHD and might be started on ADHD medications. He's overweight and he has big tonsils. So here's the grading system. And so it's really here, size 3 and 4 that we're worried about. One of the things you have to be careful about, when a kid opens their mouth and goes, ah, the first thing that happens is you get pharyngeal constriction and those tonsils squeeze together. So you need to let them relax and look at them when they're relaxed. Because we'll get kids sent in all the time for tonsillar hypertrophy. I'll look and I'll say, okay. And then everything opens up and it's like, no, they really don't have it. So be careful about when you look. But it can cause obstruction. Nasal obstruction, because the coena is blocked from an adenoid bed. It contributes to chronic otitis media. Again, you want to do adenoidectomy with the second or third sets of tubes, obstructive sleep apnea, failure to thrive, ADHD. I'm a surgeon. I think if you're thinking about putting a kid on Adderall or something, or Ritalin, you should get an evaluation for sleep apnea or consider tonsillectomy first. Exacerbation of asthma because of upper airway resistance, craniofacial growth abnormalities. Sometimes the orthodontist will send patients in to get a TNA done before they start pulling the teeth back in. And speech developmental abnormalities. They can't get the sounds out of their nose, so they always sound hyponasal. You want to get a sleep study if you can, certainly in really little kids who are at higher risk for surgery, if there are other medical problems, craniofacial abnormalities, obesity, sickle cell disease, neuromuscular disorders. If you don't know, kids will be sent in to me and I can't get a clear history from the parents, they don't look too bad, I'll send them for a sleep study and say, hey, let's get the sleep study and we'll do surgery based on that. Clinical guidelines for tonsillectomy and for hypertrophy, again, obstructive sleep apnea is the main indication, but the other ones we just talked about. Growth retardation with failure to thrive in really little kids because they can't eat and breathe at the same time. Poor school performance because they're falling asleep. Bedwetting in an older age. We'll sometimes have 6, 7-year-olds still bedwetting. It could be undiagnosed obstructive sleep apnea. I'll do surgery for that. I think asthmatic kids is something you need to look into. Behavioral problems, as I said before, and again, orthodontic problems. So, any questions on that one? Pretty straightforward, I think. Patient 5 is 17-year-old with a few days of sore throat. Developing more pain on the right side. She is having difficulty opening her mouth and eating. So this patient's developing a peritonsillar abscess. Again, most likely group A beta hemolytic strep, but you can also get other types of infections like staph pneumonia, pneumococcal, mixed aerobic, anaerobic infections, actinomycosis can probably be there. And that's what I think, let's get to that actinomycosis a little bit. Sometimes I have these older kids and young adults, my throat chronically hurts, aches all the time. You culture them, nothing's there. Do the tonsillectomy, oftentimes actinomycosis is found on pathology or reported on pathology. I think an over-colonization of actinomycosis creates a chronic sore throat. And you don't see it until you do pathology because you can never grow that, which I find kind of interesting. But most of the time, if you do cultures, growth is mixed with both aerobic and anaerobic organisms. But I haven't drained a peritonsillar abscess in 7 to 10 years. Kind of like the development of the treatment of appendicitis where you operated on everybody and you wanted a bunch of false negatives. I treat peritonsillar abscesses medically. This is a Kaiser Permanente protocol. I grabbed it because it was a nice protocol that was on the intranet. This was from their emergency department. They hydrate. I'm a big fan of dexamethasone. I'm a big fan of dexamethasone in it for adjuvant therapy for mono, for tonsillitis, along with antibiotics. It really makes the kids feel better. I put in parentheses kind of my edits on this in terms, because I'm talking to pediatric providers, but I use 0.5 milligrams per kilogram. Because they were in an emergency room, gave a ceftriaxone. I don't know if ceftriaxone is important. I treat with either clindamycin, penicillin, or we have Zosyn here is a good choice. After discharge, send them home on the oral equivalent of what you've decided to use. In their protocol, they observed for 1 to 2 hours to make sure they did well. You can get 75% of people better with peritonsillar abscesses by treating medically. So again, you select for that 25% that needs surgery. So the days of having to come in and drain emergently are in my opinion, are over. If the kids aren't eating well, admit them to peds, give them the IV antibiotics, give them hydration, and most of the kids can go home after 24 to 72 hours. Yes?
So we've recently had an influx of PTAs that have had to be admitted overnight for concern that they may worsen. If only 25% of patients on this protocol are actually going to worsen, would you say it would be appropriate to discharge them in the ED after 1 to 2 hours of observation with close follow-up, like within 24 hours?
Sure, I think that's perfectly reasonable. It all depends on PO intake, right? If they're not eating, you want to admit them, hydrate them up. Again, right here, that's the key. That dexamethasone is the key. You give them that dexamethasone an hour or two later, most people with peritonsillar abscesses are feeling better. Same thing with mono. Most of them are feeling better. That's like a miracle drug with these patients. Get the antibiotics in there, and so one assessment would be the more trismus they have, the less likely they're going to do well with their oral intake. But if you really hydrate them up and get them started on therapy, most people get better. Yeah. The other thing, I think this might be right. Yeah. So they did a study that showed, and everything's in the reference areas, medical therapy did as well as surgical therapy with no significant difference in treatment success or complications. The medical therapy group had less liquid opioid prescriptions, so obviously you don't cut them open, they don't have as much pain. We reported fewer sore days, so actually got better a little bit quicker, and required less days off from school or work. The other thing you have to understand is, as I pointed out, I think one peritonsillar abscess does not need surgery, right? It's very common, especially in the teenage group in the college campuses. Lots of kids get peritonsillar abscesses. So I'm not going to do tonsillectomy unless, you know, if they come and say, I'm always getting infections and stuff, and this is kind of the culmination of that. Okay, that's a discussion we can have. But I'm not going to operate for one. I will operate for two. But once you have more than one, you have to look for an unusual source. There was an article that I read just a week or two ago where a young woman had a second peritonsillar abscess, and it was trachomatis. It was, she was having oral sex with her partner and she got infected. So again, something to consider for repeat offenders, that it might not be as clear cut as you think, and you might, you know, we might need to get some cultures on those patients. So, so I hope I didn't talk too fast. I hope I covered everything that you were interested in, and I hope you enjoyed the talk. You're welcome. Yes, sir.
A 3-year-old who has large tonsils, sleep apnea symptoms, large uninfected tonsils, and 4 months or more to a sleep study, what do you do?
Yeah, it's kind of like that hearing test thing. I'll operate on that child. The Downs kid, the really obese kid, I might want to get a sleep study first, just kind of so we can see where our starting point is. You know, because in that kid there, if they have those other comorbidities, we'll want to keep them overnight. Or mom says, I can't sleep because this apnea is so bad, we might want to just keep them overnight anyway. But I'll operate on that child. Yeah, 4-6 months. They closed the sleep study down overnight the other day, and it's like, well, how did they do that, right? So.
Yeah, so in those situations, yeah, your important decision is, should you have the child observed afterwards?
Correct.
And historically, you've used knowledge, particularly in children with Down syndrome or other medical conditions and comorbidities, using the sleep study to gauge the need for that.
Right.
And even, you know, the potential benefit of doing the tonsillectomy in the first place. So you guys are in a tough spot.
We are in a tough spot, but so are you, right? But you got, any of you go down to the New River Valley to work? The pediatricians down there are just so nice, you know, would say, we have a patient we want kept overnight, no problem, we'll take care of them. It's just a fabulous situation to be in, because it's not been you.
I'll be there next year.
Because it just takes the worry off of me. Now, a Downs kid, a kid with a craniofacial abnormality, under 3, we'll send up here because we don't have a PICU down there. And we have Shannon Folk now. Have you met her? She joined us. She's really great. So we've been sending her those type of kids so that she can work with you guys in case there's some critical care needs for those kids.
Dr. Drake says AOM with rupture has a variety of recommendations, from treatment with drops to no treatment to treat with oral. Do you have specific ENT recommendation resources? Up-to-date cites no studies and recommends oral antibiotics.
Yeah, I know. I would treat with drops. I think the option is there for no treatment as well. I wouldn't treat with oral antibiotics because the body is taking care of the infection. The body has shot that infection out, created that hole for you to get better antibiotics in higher concentrations, right? You have to understand, this is essentially an abscess cavity, right? With a bony wall. The actual concentrations of antibiotics we get into the middle ear space is relatively low because they have to diffuse in there. There's not a blood supply in there. So anytime you have the option to use topical antibiotics, I think you should use it. That's my personal opinion.
You have to maybe tell me your opinion. Virtual diagnosis and observation, monitoring of repeat otitis media by, you know, virtual visits, apps for visuals, for picturing and doing virtual.
I'm going to qualify that statement by saying I'm an old man. I'm old school. I trained in a different era. I think that's malpractice.
From what you described, I think it would be difficult to do adequate service for a recurrent otitis, even initial otitis.
Yeah, I mean, it's impossible. A lot of the kids we see being treated for otitis media are actually, I think, cutting their teeth. You know, they're in pain, they're pulling at their ears, and they're cutting their teeth. You know, referred pain, same nerve, trigeminal nerve, or glossopharyngeal nerve, vagus nerve, they all have branches. It comes, if you go to your phylogeny, if you look at embryology and fish anatomy, they all go to that otic window that fish have, right? And as we develop in terms of mammalian development, all those nerves are pulled elsewhere. Significant amount of quote-unquote ear pain in both kids and especially adults is referred pain. They're cutting teeth, they've got something going on in their throat, they've got something else, and what do you? TMJ, and they're not having otitis media. I think it's really wrong to be using telehealth to treat middle ear disease. And especially when, look, we, again, as I said, we teach a lot of BCom students. We each bought for $19.95 on Amazon a little video endoscope that sends the picture to our iPhones, and I can stick it down the canal, and I can show the patients, and for $19.95, it's unbelievable, right? B-Bird or something like that. So when you've got the tools to do it properly, I think that you shouldn't be treating without observation. Carilion doing a pilot program, I understand, and I don't quite know why they're going to be given that type of technology to parents. They should be giving that technology to some of these family practice and urgent cares out in the community. They got a grant to do this. So anyway, did that answer your question?
I have actually 3 questions, quick questions.
Yeah.
First question is about the ear tubes. So when they come to the clinic asking about when this ear tube will come out, usually it should fall off by itself within 2 years, right? But if it's like 3 years or more than that, do you want us to send this patient to you so you can take this tube out? Or?
Yeah, good question. So there are 2 types of tubes. There's the standard grommet tubes or beveled grommets. That's like a bobbin for a sewing machine. Those are what that's the standard tube. Doesn't matter whether titanium, fluoroplastic, silastic, they're all kind of about the same. Those tend to stay in 6 months to a year and a half, okay? For repeat offenders, or the Downs kids, or the cleft palate kids, are probably gonna need multiple sets of tubes. There are something called T-tubes with little flanges. They look like T's. Those are designed to stay in for about 3 years. There's no permanent tube. And so, to answer your question is, for that regular kid where there's a retained myringotomy tube, usually that's happening in one ear and not the other. So we've got a control situation. If the ear where the tube fell out has been good for a year, we should pull the other tube. If the tubes have been in for more than 3 years is when I tend to pull the tubes. Between 2 and 3 years, because the incidence of perforation goes up.
And in a situation where you have a patient who comes multiple times with colonized strep infection, you mentioned that this is most likely colonized and you need to treat, but when they come with all those symptoms like fever, sore throats, do you just tell them that most probably it's colonized? What's the proof that they are colonized?
Well, again, first of all, it might not be strep, right? They could be getting other causes of tonsillitis. But that's where the culture is imperative, right? The carriers aren't necessarily going to be culture positive. I suppose they can be, but on rapid strep tests, they're always positive. I would do a culture and find out where you're see if something else is growing. But again, you're not testing those people in between necessarily. So those could be true recurrent acute strep infections.
last thing is with the peritonsillar abscess, we are seeing tendency in the ED that everyone with anything, he will get a CT scan immediately. Is it something that's like, should be done to exclude retropharyngeal abscesses rather than PTA, or it's just a clinical diagnosis and we are overdoing this CT?
It's a clinical diagnosis and you're overusing CT scans. Definitely, yeah. I mean, if there's swelling down here, you know, you have to look at the patient. But if you look in the back of the throat and there's a bulging of that peritonsillar pillar and the tonsil is pushed over, that's a peritonsillar abscess. That patient does not need further imaging.
Sorry, if anyone else has questions, I'm sorry, I asked a lot.
I'll get you next, go ahead. Let the resident talk.
So, I've only seen this a few times, but I was curious as to your perspective. I've had a kid before that came in with what you would typically describe of like an acute otitis media. They were really uncomfortable. They had been spiking fevers. They were pulling on their ears. Their tympanic membrane looked red, but they actually had tubes in place. What would you suggest for that scenario? Would you watch it?
Good question. That kid might have, that's going to, and you're not seeing purulent drainage or anything. Tube is nice and patent. You think the eardrum's red. That's the flu or RSV or something else. That's a viral cause of otitis media. Yeah, for sure. Yes, sir.
I just wanted to ask you to speak to the use of earwigs for.
Yeah, well, the whole point of an earwig.
Otitis externa.
Thank you for coming. The whole point of an earwig is obviously if there's so much edema in the canal, you can't get the ototopical drops in. So very important to use. And that just sucks your antibiotic. And the other thing to remember is if you're going to use drops, you have the tragus is the cartilage in front of the ear. We all know that. That's a plunger. If you don't plunge, the drops don't get in. It's a blind space. For otitis externa, there's a tube there when there are tubes in. But if you don't plunge, the eardrops sit there and they don't actually get in where you need them. So if you're going to put somebody on drops, make sure they plunge the tragus and use it as a plunger. Somebody actually did that, the cadaver study looking at this, and showed that just putting the drops in without plunging, and lots of people think you should wiggle the ear like this, doesn't work. You got to plunge. You got to use that as the plunger.
For otitis externa, do you use only Oflox or Oflox with dexamethasone?
I either use ofloxacin or ciprofloxacin dexamethasone drops are kind of what I use. You can use just plain ciprofloxacin. Oftentimes the ciprofloxacin drops are ophthalmic drops are cheaper than the otic formulation, and the other thing about the ophthalmic drops is they're not as acidic, so they don't hurt as much. So if you have parents who are worried about the pain, prescribe eye drops, okay? Now, when do I choose, when do I want the dexamethasone and when do I don't? I do when there's a granuloma, a tube granuloma, which is a foreign body reaction against the tube, or a lot of swelling. I'll use, but if it's just a standard swimmer's ear and you can kind of see the whole thing, I just use the ofloxacin drops, and that's what I use with tubes as well.
Thank you.
Thank you very much.